Wear is basically wear and osteolysis. Progressive loss of bearing surface from the material secondary to mechanical or chemical action. They can be divided into a chemical wear, which because our body has fluid and solutions, so it's a chemical environment which causes the wear, or mechanical. Mechanical wear can have mechanism of wear and modes of wear. Mechanism of wear. They can be either adhesive, abrasive, or fatigue. Adhesive means due to bonding between two material surfaces pressed together. Material pulls away from the weaker surface. This is called adhesive wear. Abrasive, asperities of harder material eroding the soft one or from the third body. This is called abrasive wear. Fatigue, failure under ultimate tensile strength due to repeated cyclic loading. This is also called delamination or subsurface delamination and relates to stress strain curve and material stiffness. Regarding the modes, it can be between two normal bearing surfaces or intended by the designer. Number two, it can be with the bearing and non-bearing surface, like for example, femoral head goes out to the metal shell and falling a polywear, and then it hits the cerebral shell. This is a type 2 mode of wear. Type 3 is a third body wear when there is a material, for example, polyethylene, which is entrapped in between, and that causes wear. And then two non-bearing surfaces, for example, troninosis or backside of acetylene polyliner and the shell and the femoral neck against acetabular shell. Regarding another way is divided into quantification like volumetric wear and linear wear. So volumetric wear is directly related to the square of the radius of the head. Depending on type of articulation, lubrication, and the load. Linear wear depends on the height of the material or distance prosthesis has penetrated into the liner. What are the factors which can affect wear? Patient factors, implant factors, and surgical factors. Regarding the patient factor, level of activity, BMI, and comorbidities. Implant factor, modular, non-modular. Polyethylene thickness, fixation method, implant constraint, and bearing material used. Surgeon factors, soft tissue balancing, surgeon experience, third body wear, implant orientation. Effective joint space is an area around prosthetic joint where fluid can dissipate freely. Wear type, titanium is a poor resistant to wear. UMHE is 100 to 200 micrometer per year. High cross polyethylene is 40 micrometer per year. Metal on metal is 5 micrometer per year, and ceramic is 2.5 micrometer per year. This is the lowest year with ceramic on ceramic. When the wear particles happen, it can cause synovitis, aseptic osteolysis and loosening, systemic distribution, immune reaction, increased friction of the fluid, and misalignment of the joint and catastrophic failure. Regarding aseptic loosening and osteolysis, first step is particulate debris formation. Second step is macrophage activation. Third step is prosthetic micromotion. And fourth step is debris dissemination. In step 1, particulate is produced. This can be either of the modes. Then in stage 2, a macrophage activates osteoclast genesis and osteolysis. Particles result in macrophage activity. Macrophage release osteolytic factors, cytokines like tissue necrophilic alpha, osteoclast activating factors, oxides, hydrogen peroxide, acid phosphatase, interleukin 1 and 6, and prostaglandins. Osteoclast activation happens and osteolysis. It is by increase of TNF alpha, which increases the increased level of VEGF, which enhances rank and rank L activation. Then is rank L mediated absorption, In stage 3, there is a prosthetic micromotion. Osteolysis happens, and then there is a micromotion, increased particle wear, and further prosthetic loosening. It can be checked by antilopeptide turnover, which is a marker of bone turnover, and elevation in osteolysis, and telopeptide urine levels. And then there's depressed dissemination. Increase in hydrostatic pressure lead to dissemination of depress into effective joint space, and dissemination and propagation of osteolysis.